So I'm happy to introduce the next session on capturing standardized patient-centered outcome measures. And our moderator for this session is Jason Beneciuk, Associate Professor in the Department of Physical Therapy at the University of Florida and Clinical Research Scientist at Brooks Rehabilitation. Dr. Beneciuk has been supported by the National Institutes of Health, the Patient-Centered Outcomes Research Institute, the Center on Health Services Research and Training, CoHSTAR. He's a current CoHSTAR Fellow, and the Foundation for Physical Therapy Research. His research interests focused on musculoskeletal pain, psychologically informed physical therapy, implementation science, and health services research. He teaches evidence-based practice in the entry-level Doctor of Physical Therapy program at the University of Florida. Dr. Beneciuk currently serves as Associate Editor for Physical Therapy and Rehabilitation Journal, or PTJ, an International Editorial Review Board member for the Journal of Orthopedic and Sports Physical Therapy, or JOSPT. In 2021, Dr. Beneciuk was recipient of the Eugene Michaels New Investigator Award from the ABTA. And as I mentioned, he's a current CoHSTAR Fellow, and I'm happy to work with him regularly. So now I'd like to have Jason, come on up.
Thanks, Dr. Resnick, for the introduction. Thanks for agreeing to be my mentor for the CoHSTAR Fellowship. And thanks everybody for being here today. See a lot of faces that I often see on Zoom, and seeing people in person again for the first time is always interesting, and look forward to having some conversations. So this session, as you can see in the title, is titled Capturing Standardized Patient Outcome Measures. So session A, Lisa and her speakers really set us up nicely for the selection of measures. But now we're going to really talk about, okay, we've selected the measures as a health system. Now we actually have to go and capture those measures. So we are fortunate to have a really exciting group of speakers representing different settings. Dr. Danny Young represents the acute care setting and will also represent University of Nevada, Las Vegas, as well as Johns Hopkins. Ms. Julia Carpenter, coming from Shirley Ryan AbilityLab, will actually talk about her experiences in inpatient rehabilitation. Dr. Michael Johnson will represent BAYADA Healthcare and talk about experiences in home health. And we strategically kind of selected speakers from different settings to share different stories and testimonials about their experiences working with their clinicians and the patients they provide care for. And last but not least, Dr. Stephen Hunter will represent the outpatient setting coming to us from Intermountain. So these are my introduction slides to kind of set the stage for this interesting session. So those of you that know me, I'm an avid baseball fan. And being an avid baseball fan and having a team that's really doing well this year gives me the permission to use some baseball analogies. I will tell you before I share my baseball analogy, I've been called out by my colleague, Dr. Maggie French, for using this analogy that's been used by others in the recent past. So I'm gonna have to give credit to some people. First and foremost, Dr. Tony Giolito, he used this analogy that I'm gonna use. And secondly, I'm sitting right next to Trevor Lentz, who also used it in a recent paper, but I don't care because I think this is a great analogy and my team is doing very well this year. So I'm sure all of you are familiar with the Field of Dreams. And in that movie, Kevin Costner, his dream was to build a baseball field in the cornfield with the hopes that if we build it, or if he builds it, this never works the way that you plan it. If he builds the field, the players will come, and in Field of Dreams, they actually did come. Shoeless Joe Jackson and some other baseball players actually came and played the game of baseball. So great movie for baseball enthusiasts, great movie in general. But related to this session, if we build it, if we select the measures, like session A talked about, will they really come? So in essence, will the clinicians really collect the measures if we provide them with the measures to collect? And then session C will really focus on the infrastructure for doing that. Patients and clinicians report the benefits of using patient-reported outcome measures, but I think everybody in this room understands that it's a really challenging process. It's a challenging endeavor to undertake in clinical settings, which is why I think our speakers have been really successful in that area, and we're fortunate they're going to share their stories with us. I don't know what's going on now. I'm not doing anything. So the objectives for this session will be helping participants understand a variety of approaches to address stakeholder priorities, needs, preferences, values, and workflow when considering and collecting patient-centered outcomes. And like I mentioned earlier, we kind of take a multi-pronged approach here in terms of from a macro level to a micro level. And this figure here really demonstrates one example of that. Okay, we can talk about looking at and implementing outcomes from a system level all the way down to the actual individual clinician and his or her patient. So like I mentioned earlier, these are our speakers, and we're really fortunate to have this group assembled. So without any further ado, I will introduce Dr. Danny Young.
What a privilege to be here with such great people. I really appreciate it. And I've got more slides than I have time to cover. And so I hope that you get handouts and can look at in more detail at some of the things that I'm not going to have time to go over. But I want to just lay the foundation for why we have done some of the things that we've done in the acute hospital setting. And that is because it's bad to lay in bed all the time. Most of us don't get enough opportunity to lay in bed to know that this is true. We would like to lay in bed more. But the truth is that spending too much time in bed causes problems. And we've known it for a long time. And despite that knowledge and understanding, we continue to keep people in bed when they're in the acute hospital. And this is just one study that illustrates how little time people spend out of bed. And so when comparing the mounting and or known evidence of bed rest harm to practice, we really heavily leaned on this model of translating evidence into clinical practice and used this framework to inform the steps or the components of the effort to get systematic measure put into place. I'm not going to have time to talk about all of the program components that we have, that we use in order to make that happen. But this slide is a nice summary. And as I talk about the effort to implement systematic measurement, the one takeaway from our efforts that I hope resonates with you is that at its core, the effort is that every day, every patient in the hospital has a personalized mobility goal. And that everyone knows what that goal is, that we're all working on that together. And so as I go through these slides, I'm going to focus on some of the components that we used, particularly to try and instantiate that within clinical practice. You'll notice that number 2 on the list was systematic measurement. It's really hard to know if you're changing patient mobility if you don't measure mobility in some way. Most clinicians in the acute hospital know of the evidence that bed rest is a problem, and they believe that they are doing the best things for their patients. When you talk to clinicians, when you talk to nurses and therapists, of course, we mobilize our patients. But when we look at that objectively, we find that's not true. So we need to measure it. And that's what I'm talking about today. I loved some of the comments that we heard about tool selection. And those were certainly considerations in the tools that we picked. And the tools that we landed on after a process that included some of the components you heard earlier were twofold. One, to try and understand patient capacity. In order to have a mobility goal, you have to know what patients are capable of doing. And that assessment has to be personalized. It has to be, what is this person capable of doing today? Too often in the acute setting, efforts at mobility are simply get everybody up and walk, or walk 3 times a day, or get out of bed twice, up for meals. But our effort is centered around the idea that we can know what people should be capable of by actually measuring that, and then trying to measure what they do. The way that we measure what people are capable of is with the 6 clicks. And many of you are familiar with this, but there are 6 items in this tool. And each of these items is scored on an ordinal scale based on how much help from another person is needed to accomplish that task. And that gives you an overall score for both mobility and daily activities. And in order to inform both the efforts of physical and occupational therapists, we try to get both of these scores on patients. On the performance side of mobility, once we know what someone is capable of, that can help us set a target for what we want them to do, and also to record what they ended up doing on that same scale. And at the heart of this effort is this mobility goal calculator. You'll notice if you look closely, and I think on the left-hand side is the AMPAC score. So if you score that 6 clicks, the mobility 6 clicks, you get a score, and that tells you what the patient's goal should be for the day. And then the levels that you see in the main box there are the Johns Hopkins highest level of mobility scale. That both serves as the target and then as the documentation for what actually occurred. And one of the things that we've done recently is try to incorporate meaningful activities around ADLs that can also help facilitate patient, provider, caregiver recognition of what sorts of things would lead to accomplishing that goal that might be meaningful. On the workflow integration side, in terms of getting this to happen regularly, that was one of the things that we heard about earlier. You've got to build workflows around these measurements in order to make sure that they're captured consistently. And part of that is building this into the EMR, and I'm glad to see that Kelly Daly is here today. She was instrumental within the Hopkins system of helping us to work with clinicians and from an informatics perspective to know how can we build these measures into our electronic medical record system in a way that everybody can see it and can use that information and that it shows up in the right places for the right people. There are other items on here that you can see that are also helpful and important when it comes to instantiating a systematic measure in a setting like the hospital. And these are places where we try to do that, some more prescriptively and some less prescriptively. The other component that I think is important to highlight when thinking about making it stick, because we heard earlier about getting these measures in place with varying levels of success in capturing them. And one of the things that we've done that I think is very helpful is essentializing reports that can feed back the data on what's happening to the clinicians who were expecting to perform these tasks. We do this in a couple of different ways, but it happens regularly. In most cases, we do this monthly, and we do this with a couple of different groups. We do this with unit managers, and we do this with clinician specialists. And they're asked to review their documentation compliance and patient mobility goal achievement as a group. And the peer pressure that happens when you see your numbers alongside people around you seems to be a helpful way to make sure that people continue to participate in collecting these data so that we have them. This is an example of one of the reports. And so I went pretty quickly over how did we get that into place, and I can go back during the Q&A about some of those steps, but I want to highlight what these data look like when we get them and then can feed them back and use them to drive care once they're in place, because I think this is part of getting it in place. This is a report on documentation compliance for different units, and this is made up data, but this is how it would look for different units along the left, nursing units, over time. And again, if we present this to the group, the peer pressure of being in the yellow or the red as opposed to the green seems to be really motivating for leaders and clinician interests in terms of changing practice. So this is documentation compliance. Do we have an AMPAC score and an HLM score on every patient every day? That's what this is reporting. This is the report, or an example of a report on goal achievement. What kind of information do we have and how do we feed that back on goal achievement? In this case, we look at it on the left-hand side in the categories for the different goal levels, and you'll see blue and green there. The blue is when they didn't meet the goal, and the green is when they did. And you can see, and we bucket these, so you can see the goal is for a 7 or an 8. And so you can see that the 7 and 8 bars are really small and green, and the 6 bar is really big right next to it. And so this is one of the ways that when we have these data, we start feeding them back, we can point out or discuss with clinicians, why do we have so many patients whose goal was a 7 or an 8 only hitting a 6? And that conversation that we have every month with the unit leaders and with the unit clinicians really helps to sustain and or improve practice over time. And then the trend line on the right-hand side, month to month, how are we doing with goal achievement in this category of 7 and 8? I want to finish by highlighting some of the efforts that we did with several institutions around the country. These 5 systems were eager enough to try and do this, that they agreed. We had a pilot grant from LeaRRn that supported some of the efforts with one of the sites, and the other sites, we did it with their own interest in improving their practice and with in-kind support from some of the folks. The original idea was for a stepped wedge implementation effort. The pandemic made the timing of that really hard because we tried to do this right as COVID was peaking and things were all shut down. So that was an unfortunate situation, but we were able to do it, and these hospitals all, in fact, did go through the steps with varying degrees of success. And so this is a chart that just highlights those 8 steps that I put up there before, starting with organizational prioritization and then putting those systematic mobility measures in place, and then feeding back that data with reports. These different items are the rows that are listed across the left-hand side. And the red, green, and yellow are how completely did each of these sites implement all 8 of those components. And so we had variability in the implementation completeness across those sites. So even with that systematic approach, it wasn't easy to both do it and to get feedback that it happened. I'm going to finish by just highlighting some of the results that we saw in these sites. These are very preliminary data, and I know they're too small to see the axes, but here we're looking at documentation compliance over time. So you can see there's a lot of variability across sites. Within sites, there's slightly less variability. There were a couple of sites where they made changes over time, but mostly sites were pretty consistent once they started during the 6-month window that we looked at with them for documentation compliance. AMPAC on the left, HLM on the right. This is goal achievement, and here we see even more consistency, pretty flat trends except for one group where it looked like they trended down a little bit over time. But these kinds of reports and data at an institutional level, at a unit level, and feeding those back, I think are one of the keys to getting these measures to stick and then helping people to know that they are useful. I'll finish with a couple of the key takeaways that I think we saw from putting these in place and things that I think can really help us and these institutions. Again, these are preliminary. The sites that are participating, some of which are here today, haven't even seen these. And so what we've seen in some of the measures, when we look at goal achievement, the blue is patients whose initial AMPAC score was quite low. So these are people with high physical impairments. And so their HLM goal during the first 48 hours of hospital admission was a 2 to a 4, which is in bed or edge of bed kind of activity level. And their goal achievement was consistently lower than patients whose HLM goal was to be ambulatory, to be a 7 or an 8. These are people with fewer functional impairments during the first 48 hours of admission. So people went on during admission to achieve their goal more or less often based on where they started. Now, this doesn't sound super surprising, but as an institution, it helps you to recognize that if you're collecting these data and then feeding them back, that we need to probably do something better for our lower functioning patients. They're not getting enough help. One of the other things that we've looked at, again, very preliminary on some of these results, is that there's a direct relationship between discharge disposition and goal achievement. Patients whose goal was lower, so these are people with more functional impairments, when they met their goal more often, they were more likely to go home. Patients whose function was good, it didn't seem to have as much of an impact whether they met their goal or not. They were going to go home in about the same numbers. But those lower functioning patients, if they met their goal more often, their chance for going home went up. And this is another, I think, critical kind of data that we can feed back once we start collecting these measures to help us. So a little bit of how did we get the measures in place and what can we learn from them, which I know is the next section, but I was too excited not to share some of that. So that's all for me. Thank you.
Hi, thank you. I'm a little shorter. My name is Julie Carpenter. I am a speech language pathologist at the Shirley Ryan AbilityLab, and I am a clinical practice leader. So I sit in the staff development department, which has a focus on training and education of allied health clinicians. And the work that I'm going to present today is really some work that many individuals in our organization have been part of. And so I just want to acknowledge all the contributions of my other clinical practice leaders of PT and OT backgrounds, as well as information systems and our data and outcomes departments. But I'm going to be talking a little bit about the capture of standardized performance-based outcomes from the lens of inpatient rehab. And just to give context, our inpatient rehab is 262 beds. We have 8 inpatient floors. And in terms of the staffing of allied health clinicians on those floors, we have roughly 6 to 7 PTs and OTs per floor, 2 to 5 SLPs. And then we also have AbilityLabs, which have clinical specialists in particular areas. So perhaps somebody with a specialization in dysphagia or a specialization in cardiopulmonary rehabilitation. And with that, we see a variety of patient populations with neurologic, brain, and spinal cord injuries. We see general rehabilitation populations, cancer, pediatrics. And really to talk about the impetus for where we started roughly 10 years ago when it comes to outcome measurement, I'll go back to what many of you are familiar with, which was the IMPACT Act that was the impetus for standardizing functional item reporting in post-acute settings. And if you're familiar with the section GG of these of the standard functional items, you'll be familiar with items for self-care, for mobility. I haven't even listed the items for cognition and communication because they are so minimal, but those are the standardly reported items to CMS, and then the scale on which they're measured is a 6-point scale. So really one of the reasons why our organization embarked on improving our ability to capture additional outcome measures had to do with the limitations of those scales. So at the time, 10 years ago-ish, we were unhappy with the FIM items and then what would become those GG level items because they were poor at capturing the ways that our most severe and highest level functioning patients change during inpatient rehabilitation. They really lacked the specificity of particular domains of measurement. So as I mentioned, the newly released GG items have very limited measurement of cognition and communication. And we felt like we were going to be really challenged with being able to demonstrate the change that our patients in rehab were demonstrating at the inpatient level. So this became really an institutional priority set at the highest levels of leadership articulated by the CEO and the leadership team this became baked into our organizational goals across many years. And I'm just giving this background because I think it's really important to talk about some of the successes that we've had with Capture, that this is a well-supported initiative. This resulted in additional funding support for allied health, clinical staff, an EHR modification, collaboration among clinical outcomes and data teams. And what we have developed out of all of the outcome measurement that we have been able to capture is something that we have felt met our needs in terms of demonstrating more specific measurement of patient change during inpatient rehabilitation. So there is a composite rehab outcome score that we use called the ability quotient across these different domains of function. And these are some associated papers if you're interested in the AQ. But this measure has demonstrated improved measurement at those higher and lower functioning patients, better at measuring change over time. And it has allowed us to develop predictive models at diagnosis and individual levels. So for anyone who's looking at those functional items as compared to more standardized outcome measures, this isn't a surprise that they're better at measuring patients' change in function. But what we're excited about is that we're beginning to use this information in our interdisciplinary inpatient team conferences so that clinicians, physicians, nursing teams are all looking at patients' progress over time on this composite rehab measure and have the ability to compare this measure to predictive models to see and make judgments about whether the patient is on track and what can be done or altered about the plan of care in order to help the patient get back on track with prediction. To get to this point, this is really kind of the crux of my 15 minutes, is to talk about the capture of those standardized outcome measures and the methods that we use to successfully get there. So the prior conversations talked a lot about clinician engagement in the selection of patient-reported measures or in some of the other measures that we're talking about. And we used a similar process where clinical stakeholders were the ones who selected and appraised the evidence for various measures. And we piloted all of these in our clinical practice before integrating them in the EHR. So we've come along this trajectory and we're now replicating the process in our day rehab level of care, which is kind of a separate sidebar conversation. But again, what I'm going to focus on is what have been successful methods to use in terms of medical record modification, both from the data perspective as well as from the clinician stakeholder perspective. So in terms of some of the thinking and behind what we wanted to do in our EHR is Cerner. I know not everyone, most people don't use Cerner, but we still do. And we have the capacity to modify our EHR pretty routinely with the help from our information systems teams. In terms of the data, we wanted to be able to capture item level data on our assessment measures. So much of our prior EHR data before this project initiated captured things like raw scores, standardized scores, scaled scores. But we proceeded with building in record forms that had item level information for each assessment tool. We put in some field limits so that data entry could be incorrect data entry could be caught early and feedback given to clinicians if they had, mistyped a numeric value. There are various required fields built into the documentation so that, again, we have a catch in case someone accidentally skips an item or if a patient doesn't answer an item, how do we handle that type of missing data? And then we also have indications in case something was not completed. Our psychometrician and statistician really recommended that if you are going to miss data, we want to know why. Was the patient unable to do it? Were they not appropriate for it? Did you not have enough time, et cetera? What was the constraint? And then we really tried, and this prior talk that we just heard talked about the reporting piece and being able to give clinicians and teams feedback about their compliance with outcomes assessments. In order to support clinicians, and this is where I think having clinicians be part of the design process is really important. Many of these features are requested by clinicians, initiated by clinicians. We have individual documentation forms built outside of our regular evaluation so that those can be captured at any point in care. Something as simple as having the ability to calculate and auto-populate scale scores is huge on the clinician end. If you can save people from having to do the math and use reference text, that's really helpful. We also built references throughout the EHR with normative values, with assessment and administration instructions. So really, we want the EHR to serve as that point of care place where you're documenting, but also getting the appropriate references that you need to make clinical decisions for your patients. We also were mindful about making sure that clinicians had access to longitudinal views of the data, so they could easily toggle and see when was the last time measures were completed, what were the scores, how is the patient changing. And then finally, we integrated this feature of allowing clinicians to initiate orders themselves about the measures they thought were going to be appropriate for that patient's plan of care. And we used just an orders feature in Cerner. So this screenshot you can see is an example from physical therapy. Therapists can select the measure and the frequency that they want that measure to be administered. And this was really helpful because oftentimes in our large organization, we'd have different clinicians maybe coming in the second or third day after a patient's being admitted. And we wanted a way for clinicians to be able to communicate with each other about what needed to continue to be assessed. We've kind of talked about this a little bit today, that not every measure fits every patient. And this was our way of being able to capture that and allowing clinicians to make decisions about which measures they thought were going to be useful for measuring outcomes in their patients during their stay. In terms of the measures build, we've built over 40 measures across the allied health disciplines. These are both inpatient, and at this point, this list contains measures that we're building more for our day rehab level of care. And I would say, again, to reiterate, not every patient is appropriate for every single one of these measures, or might not be appropriate now for the measure. They may be appropriate as they transition back home to the community and are attending outpatient or day rehab services. But this again allows clinicians to be able to select measures that are appropriate to their patient and patient populations. In terms of goals, I'm just sharing one example from the speech pathology data, although we have very similar trends across PT and OT. So our operational leadership was in agreement that we could have goals built into our performance management system so that annually clinicians were evaluated based on their compliance with these goals. And the first goal was just that for your patient, did you initiate the assessment order in order to communicate to everyone else what the continuing ongoing assessment plan would be for the patient? That was a goal that pretty much all disciplines met out of the gate. They didn't really have a challenge doing that change in their workflow. It was very easy for them to initiate that. The second was a goal around, for the measures that you thought were important, did you complete them at least twice with your patient during their inpatient stay? So this was a very preliminary initial goal as we were beginning to encourage adoption of outcome measures. And what you see on the screen is really kind of a distinction in timeline in terms of the phases of the project. So in the first phase, where we were just getting up and running, clinicians were given lots of training in the standardized performance of these assessments, how to score them, how to interpret them, how to document them. And they were given reminders to continue to assess patients, to continue to do these measures. And that only led to, about, 50, 60% adoption of this adherence goal. Once we started to give feedback back to the clinical teams and managers through reporting, that's when we saw teams begin to change their practices. So I just want to emphasize that as something that has been really important. And usually what clinicians would tell us is they would say like, oh, I thought I did that twice with so-and-so, but they weren't really keeping abreast of that on an individual patient level. And so this really helped them focus in on that particular goal for outcome measurement. In terms of our current strategies for improving the capture of data. I think one piece that's that we haven't talked too much about yet is really how do we ensure that clinicians are performing assessments in a standardized way and are scoring and interpreting assessments in line with how they were intended to be interpreted. And so we have baked into our new hire orientation, clinicians typically get about 150 hours of protected time, not just for outcome measurement, but in total as they onboard to the organization. And we've been able to carve out with alignment with our operational leadership, some time that they can spend both asynchronously and then in live labs on outcome measurement and case application and discussion and practice. So we want to be able to train clinicians to do these measures, do them well, and feel comfortable interpreting them. Some additional resources is that we embed summaries with the psychometrics, populations, administration scoring, these easy tools to reference for clinicians who are current staff who may need to use the tools. And then in terms of our future directions, through our Center for Research Acceleration, a big question right now is to think about how accurate our data really is, how much inter-rater inconsistency is there in the data, and then how can we continue to establish high-level competencies for administration and scoring of outcomes. In terms of ongoing challenges, so you can probably, will be a common thread that assessment burden is something that we have to continue to consider, continue to discuss with clinicians. I'm really happy that we're at the point where we're having a lot of questions from clinicians about decision-making using outcome measures. So it's not just a measure at admission and at discharge, but with this routine measurement, questions are arising of how do we change and alter the plan of care given the data that we're getting from the patient, whether it's performance-based or patient-reported. And then I think the other piece that we're kind of navigating in terms of ongoing challenges are how do we embed this consistently and how we understand more composite measures versus more impairment-specific measures, and how do we integrate that with our thinking as it relates to predictive models. So that's the kind of the current place where we are, and I'm happy to talk a little bit more about that clinician lens of how do we successfully help clinicians integrate measures in their practice.
All right, well, good morning. Way. A little bit of help here. There we go. Okay. Was it nervous enough as it was, and now I've already blown the beginning. So it can only go up from here. So I'm actually really glad to be here. My name is Mike Johnson. I want to start with some, let's see if I get this right, with some recognitions, first of all, to the LeaRRn organization for making research in our organization possible, because for the last 10 years, I've been functioning as the practice president for the home health practice. And for the last 5, I've been fighting fires between PDGM implementation and COVID. I've had very little time to spend on research. And so being able to do it in a collaborative way with partners. Internally, Tony DeLonzo and Michelle Berman helped drive. Tony is the chief clinical officer for the practice. Michelle is the national rehab director. But then I also want to recognize partners on the most recent research project we did that was published in JAMA Health Network March 1st, and that's Rachel Brzezinski, which is over there, Tracy Mraz. Interesting thing is I've been working with that team for a long time. It's the first time I've seen them in person. We haven't even had a chance to say hello yet. So thank you for your partnership. And then Natalie Leland from the University of Pittsburgh. As I stated, what I have been doing for the last 15 years, I've been at BAYADA Home Healthcare for 15 years, the last 10 as the practice president. So very much into operations, thinking about learning health systems, but not having a whole lot of time to put that into place because Medicare continues to change the rules. As I looked at the presentations of the folks on the panel that I'm with, I was really impressed. Like the outcome measures, adherence and so forth, I don't have a whole lot of that. So I was feeling a little bit like, okay, am I the right person to be talking? I think so, because I'm just going to be honest. We're in the messy middle, and no pun intended. I'm here to learn. The role that I'm in now as the Chief Research Officer is brand new. I've been in it for 4 weeks. So there's a lot of folks in the audience I've never met, so I'm hoping to make some new friends. I've been spending a lot of time with friends I haven't seen in a while, like linear regression, chi-square, and my favorite, minimally clinically important difference. So I'll give you a little bit of background about BAYADA. Right, so we were founded in 1975. We're coming up on our 50th anniversary. Home health services in the home, but multiple services. We have 8 specialty practices. All delivering, well, 7 of the 8 delivering care in the home. The 8th is actually autism. We've got clinic-based autism practice. We're in 23 states. We're actually in 6 countries. We've closed down Germany recently, but we'll reopen at some point in time. And we've got about 25 to 30,000 employees. And in the home health practice, we take care of 28,000 people a day. And so when you're in charge of that, there's a lot that you have to focus on, but you have such an opportunity to make a difference. And so how do we become an integrated learning health system has been something I've been thinking about for quite some time. As I mentioned, just quickly, we have 8 sort of integrated practices: home health, hospice, private duty services, a large pediatric practice. And as the chief researcher, I'm actually involved in the research in all of those practice lines, doing some really interesting stuff in pediatrics around home intensive care units. So happy to talk about those things. But for today, I'm going to focus on the work that we've been doing and the challenges and maybe opportunities we have dealing with home health and OASIS. So as you may know, home health, well, healthcare in general, but home health is certainly a highly regulated and value-based payment setting. And part of the reason I add the value-based payment setting is we are now in 2024 was our first performance year in home health value-based purchasing, right? So outcomes have always mattered. They've mattered to us individually as clinicians and certainly to our patients and their families, and now matters from a payment perspective. And to just give you some context, upside, you can earn up to 5% on your total Medicare revenue. Downside, you can lose 5%. You can pay it back. And given the size and scale of BAYADA, that is top line. If we can maximize, it's about $25 million. $25 million, and that's important. And the reason that is important is not necessarily so we can put it in our pockets and buy a nicer car. In home health, we have to fund our own innovation. Right, technology, hospitals and physicians got help with implementation of EMR. We pay for all of those things on our own. So we think about it as an innovation fund. So the stakes are continuing to get a little bit higher and a little bit higher. And so I want to talk about that. So from an input perspective, there's a lot of data that we capture in OASIS. And so there's lots of opportunities, as we did with the University of Washington, to do some interesting research. But it doesn't always help drive the best clinical decisions. Somebody earlier, I think Claire, may have been you, was talking about who's the measure serve. Does it serve the clinician? Does it serve the patient? Does it serve the administrator? Does it serve the payer? And on the OASIS, I can assure you there are chunks of measures that serve the payer. And I get that. How do we make sure there's a balance there? So multiple mandated measures, starts of care, resumptions, discharges, and lots of different types of measures, self-report measures, provider report measures. Julie talked about the Impact Act. So M questions and the GG codes are important in home health. Quantitative measures that are part of the Mach 10 that are part of the OASIS, the Mach 10, the BIMS, the CAM, and then more global measures that we think about and we're starting to get paid on: timely initiation of care, hospital readmission is a big one. So there's a lot for us to think about and work on. And to give you just a little bit of context of the environment that we're in from a complexity standpoint. One, for a start of care, it takes a good clinician somewhere between 2 and 2.5 hours to complete that. The documentation burden is a significant issue. So I'd love to have them answer or throw in 2 or 3 more tests or measures, and then their heads would explode. And so figuring that out is important. We have and we're pretty consistent with the national average, about 40% annual turnover of our clinician workforce, which means we're constantly training and retraining folks. And so what measures can we use that are simple, that are easy to use, so that the person who wasn't here last week can now quickly jump in and use that measure effectively? We have, and maybe the case in other settings, we have 4 different clinicians that could do that start of care: the PT, the OT now, the speech therapist, and the nurse. And so for the majority of our cases are opened by nurses. The nurses are doing the functional assessments. Isn't necessarily a bad thing if they're well trained, but if it's a nurse who just came to us from the hospital who's never done any physical function assessment, again, we've got a training issue. So a part of what I want to talk about a little bit today is, I know the first group talked about selection. I can't not talk about selection. And then how do we get people to follow through on that? So just context. It's not the end of the world as we know it, but I'm not bored. Let's just put it that way. So to go through some of the provider, I'll go through these quickly. We mentioned the functional status scores. These are the M1800 scores, if you're familiar with OASIS. These scores feed and help determine star ratings, which have been important measures for us as we're talking to referral sources to try to grow the business. I'm not sure how much they've impacted patients' decisions, because in health systems, it's usually the discharge case manager who oftentimes will make a recommendation, but they're important. And right, so you can see grooming, transfers, ambulation, locomotion, for example. The concerns we have with these, and Julie spoke to it a little bit in the SNF setting, is consistency, and for us, reliability, inter and inter-rater reliability, because we've got multiple clinicians answering those questions. And then really, are they giving us the level of specificity that we're looking for in terms of our outcomes? But we've had them for a good while. Now here are the GG questions. Right, I'll give you a grab. So it looks a lot like you saw basically the same ones you saw on Julie's, because the Impact Act has us moving across. It looks a lot like 6 clicks. What's important to understand here, and the reason we're sort of in the messy middle, is these codes are now going to be used to determine the outcomes. Pre and post measures of these codes are going to determine 20% of our home health value-based purchasing measure, or score, excuse me, 20%, a full fifth of it. And so consistency and subjectivity continue to become an increasingly important role. And so that's challenging enough. But what I'm also going to talk about is Medicare, starting in January 1st, the new OASIS E1, they're going to basically project what the discharge status should be based on the data that's entered at the start of care. So wherever you get to may be good enough, it may not, because it's going to be based on a regression analysis that they've done. So all of a sudden, we have to pay attention in a different way. And so that's had us thinking about metrics and measures, and how do we meet the needs of the patient and the client, and also meet the needs of the payer. So we've got that innovation fund I was talking about. Just a quick note, MedPAC doesn't like us. Never have, probably never will. But the move to this discharge functions score is not unexpected, because they have had their own issues with self-reported provider, and I get that. That has been a limitation. And so one just quick shout out, I do want to make a recognition for the home health section. They did a lot of work on determining what tools outside of the OASIS would be reasonable to use in a home health setting. And it was our home health section group, but they looked at PTOT and speech and did a really nice job. Looked at inclusion, exclusion criteria. I highlight inefficient use of time for the home health therapist. So part of it is we're already spending 2.5 hours. You can't add anything unless it's absolutely critical. And that's an easy thing to say and a hard thing to do. Michelle Berman served on that, so I thank Michelle. And then internally, we came up with a list of the secondary measures that we would recommend to folks. And we've so far, we've sort of left it up to them. How much we standardize continues to be a challenge for us, in part because if you pick one measure, there's so much variability in the home setting, that measure may not actually apply in this person's home where it would apply in this one. And so it's a bit of a dance. So let's talk a little bit about home health value-based purchasing, this new discharge function score. Right, as you can see here, it's going to be worth. You can see that what comes in the measure set, or the outcome set, and what it's worth in terms of that. So if getting the full 5% is worth $25 million for us, not getting the discharge score is worth $5 million, right? And again, this is an innovation fund, and so how do we? That's part of it. The other piece is when you read through the creation of the discharge function score, there's some good reliability, but I'm actually kind of excited about it. But it ramps up the expectations for us as therapists in ways it never has been before. And so paying attention to that is important. And if you look at readmission, which we have a lot of opportunity to impact, those two together equate to half of the home health value-based purchasing score. And so we've got to pay attention to them. So let me just talk a little bit about this as I start to wrap up. So discharge function is going to be basically a composite of 11 measures. And you can see at the top here, 3 of them are self-care, and the rest are more mobility measures. The last 2, actually, you're doing one or the other. It's either walking 50 feet with 2 turns or wheelchair. So there's really 10 items that will make up this discharge function score. And it will be based on the input and based on other variables such as age, comorbidities, and so forth. There will be a projected score that we as clinicians and as an organization will not know what that score is. And so we got to figure out, how do we come up with a lead measure that gives us some indication that the lag measure, the score, is going to go the direction we want, because payments riding on it, more importantly, it will develop better clinical outcomes for folks. And so let me just share that with you as I begin to wrap up here. So for example, we're looking at the short physical performance battery test as a screening test for this. If we think about that, what that does for us is it gets at a lot of the elements in this discharge function cohort. So we're at least in the right direction. Maybe more importantly, it helps us identify where we're going to focus. Is it more of a balance issue? Is it a strength issue? Is it an endurance issue? And are there then additional metrics, the Berg and so forth, that we can get additional specificity, all the while tracking this and with the hopes that, and my formatting's off a little bit there, I apologize, with the expectation then that the discharge function score will come out in favor of improvement to the degree that it's expected. And so part of what we're looking at is, how do we, and so I'm interested in talking to Julie about what she's going to be, what the ability quotient. Did I say that correctly? Got it right. Because what we're looking at is, how do we, what measures do we pick for what purpose? Screening measures, clinical practice and intervention measures, and then how do we hardwire and make those sort of mandatory? Which ones do we, which ones don't we? So my conversation, again, I see Claire back there, getting stakeholder involvement and so forth is and will continue to be key. And so definitely looking for partnerships and helping to design this, but also then to be able to track it and make sure we've got the compliance that we need, because it matters now more than it ever did. So that said, I had a couple of clinical level considerations and a couple of, hang on a second, system level considerations. And for me, the one that I just wanted to point out is the organization and staffing and training for us is going to be essential, because we've got multiple clinicians filling out the same form to determine function. And if we really want to get the outcomes for our clients, we've got to have everybody sort of really understanding and rowing. And we've got 40% new people every year. So again, it's not doom and gloom. It's just a nice opportunity to try something new. And thanks to Medicare and thanks to MedPAC, we'll get this figured out and they'll change it on us again. So looking forward to the conversation and appreciate the opportunity to be here to present to you. Thanks.
All right, good. Good talks, good discussion. Appreciate the opportunity to also be included with this illustrious group here and look up to these individuals. Again, my name is Stephen Hunter, physical therapist by discipline, work at Intermountain Health, and I'm the director of our internal process control team. Odd title, I know, but this is an implementation team. We have 5 on our team that implement processes across Intermountain. So, no disclosures. Quickly about Intermountain Health. It's a not-for-profit integrated health system in the Intermountain West, just merged with the SCL group based out of Denver. So now 33 hospitals, 60,000 employees. But more importantly, there's about 2,000 rehabilitation employees, caregivers as we call them at Intermountain. So the nice thing about Intermountain is in the learning health system is our operational model, which you kind of see there fits really well with the learning health system cycle, particularly this area that we have that we call learn and share, which is really aligned with the kind of knowledge to practice within the learning health system. So this is something that's been embedded in Intermountain for decades, and when learning health systems came along, it fit really well with the way we were already doing things. So a little bit of history about our collection of our capture of outcomes in the outpatient setting. This started in 1999. A group of us got together and said, we don't know if we do any good as therapists, and how good is the care that we deliver? And we couldn't answer that question. So we decided to create an outcome collection system, and we had certain things that we wanted to do back then, 25 years ago. And those were, we wanted a valid capture across multiple clinics. At the time, it was about 40 clinics. We now have about 80 outpatient clinics. And we wanted to say, look, we can't collect measurements like strength or range of motion because that's not going to be valid across it. So we settled on patient-reported outcomes, and we settled on disease-specific ones. And I'll mention why we focused on those here a little bit later. We wanted a successful capture rate, and we set a goal to have intake and discharge outcomes so we could calculate that change at 90%. 90% of all patients that came in, we wanted to get that intake and discharge. And we also wanted to minimize the burden, as has been mentioned, specifically on our providers, and wanted to take kind of them out of the equation of having them do a lot of work. We also wanted adoption. So this is the main focus of why we were doing this. We wanted to have these therapists use these outcomes to improve the care they delivered. Okay, we weren't doing it for reimbursement. We weren't doing it for research. We were doing it predominantly then as our goal is to change the way an individual therapist practiced and to use that information. And that's another reason why these disease-specific outcomes just fit better with that goal. It's much harder to use the answers to questions in an individual patient session if the outcome is more broad in nature. And then we also wanted real feedback. So we wanted to develop dashboards along with our collection so that therapists could use it in real time. They could see their outcomes the same day or the next day. And we wanted it transparent so everybody could see everybody's outcomes. And that was kind of one of our initial goals. We also wanted champions. We didn't want this to be a top-down thing as managers telling people to collect this. We wanted it to be a groundswell where the providers themselves were telling each other, hey, this is great. You know, this is something you ought to do. And we wanted them to use it in patient engagement. Okay, so this is before we started this, right? These were kind of our vision, and I think it was a pretty high standard that we set, but you know, it was good. So this is what happened. So I know this is a little bit difficult to see, so I'll just explain. This is the current process. Patient walks into the clinic, they're asked, you know, what are you here for? I'm here for my neck pain. Okay, they're handed an iPad that has the outcome and a pain scale on it. They fill that out. It goes into our database and is integrated on the back end with the EHR and dropped into visualizations. The therapist then takes the patient back. They do their evaluation and they classify the patient. So this is critical. They put them in a homogeneous bucket so that we can compare patients to patients. We don't use ICD-10 codes for this for obvious reasons. So that's kind of how it works. So to meet some of these original goals, these are some of the things that we've done. First of all, it's the front desk that collects the outcome. It's not the therapist. So we took it out of their hands. We knew they would mess it up, frankly. So we put it with someone who would take accountability to do that, and they do a great job. On our outpatient side, we collect these outcomes every visit. All right. And with our neuro patients, we shoot to collect it every 2 weeks. Because of this, we have these front desk people script a thing that they say to the patients. Okay, Mrs. Jones, thanks for coming in today. You're going to be filling this out every visit. It helps your therapist provide you the highest quality care possible. Are you okay with that? Well, what patient's going to say? Well, I don't want the highest quality care, so no, I don't want to fill this out every time. So when we do that up front, we just don't have complaints. I mean, we just don't have patients complaining that it's a burden to do this every visit. And then, again, as I mentioned, the caregiver determines his classification after the evaluation. And then, this is key, is we really want that caregiver to engage that patient every visit with that information. So I'm in the clinic on Wednesdays and I just make it a point that when that patient comes in, I say, hey, I see that your neck pain disability index has gone down a little bit. That's good. Tell me about that. What's happening? And in that way, that patient, the next time they get the iPad is like, oh, they actually use this information. So I'm gonna fill this out. So those are kind of the goals that we have. So what are the common questions? When Jason asked me to do this, and he said, you got to stick to capture, Stephen. You can't go talking about, other things that other sessions are going to cover. And I'm like, okay. And he said, cover some of these common questions that you get, which is, well, why do we collect the outcome every visit? Because patients are going to complain. The front desk doesn't have the time and there's not enough, the measure is not going to be sensitive enough to really measure that difference over time. Well, we haven't really had those issues. I mean, the capture rate is pretty high. I'll explain it in here in a second. As I mentioned, we do scripting. One of the things at Intermountain, as I think most folks are doing, is we're seeing people in a less dense frequency. So we average just slightly over one visit per week with our outpatients, even our post-op. And so the measurement does measure a difference in change when we do it just once a week. And then the other question that we commonly get is how do you get clinicians to buy into this? Well, we've made it easy. We took most of it out of their hands. I mean, they take 30 seconds on the first eval to classify the patient. And other than that, it's just the time looking at the data and trying to make those clinical decisions. So we've tried to make that easier. And the big reason is the why. We're doing this so that they can provide better care for that individual patient. I mean, that's the primary reason we're doing it. And I think most therapists want to be better and, buy into that. And so we really have had quite good engagement from our providers. Okay, so let me give you some of the actual results here. So this is data just this year, January through September 1st. Again, I'll read a little of this because it's a little bit small. So this is the first dashboard on our visualization. And when we first started this back in 1999, the most important thing we focused on for the first 18 months was getting the data in. We set up goals. We didn't even focus on what the change scores were. We just said, look, if we don't get good data in, nothing else matters. So that's really a primary goal. So far this year, we've got about 57,000 outpatient individual patients that have entered data. And about 43,000 of those we have that came in for 2 or more visits. So we do have a lot of patients that come in for splints or functional capacity valves, and we kind of can't collect the change score with them. So we're looking at this 42,000 patients. And the really important metric that we have is, are we collecting that outcome on the last visit? And again, this is about 92%. That's gone down a little bit since we've added our neuro patients, where we only collected every 2 weeks. And so, we were up above 96%. And then with the neuro, we're still pretty happy that we're collecting this outcome on the last visit about 92% of the time. And then lastly, really critical is that therapist, is that provider classifying that patient into a group that we can compare to other like patients. Fortunately, we're doing a pretty good job at collecting that also. This is pretty critical because if we have therapists that we want to adopt this, right, that they're going to hang their hat on it, because of course, their outcomes are never as good as they think they are, right? I mean, we all think we're great therapists, and we usually are great therapists, but the outcomes that we get are not always what we think they are. And so if we want these therapists to accept that, I can do better, they got to trust the data. And for that to happen, the data's got to be complete. It's got to have some severity adjusting so that they can say, okay, you know what, I need to make some improvements here, and I'm open to that. I'm humble enough to say I need some help to improve. Okay, so with the capture rates then, how does that integrate into what the therapists do? Well, here's a few things that we've done. First of all, and Mike mentioned this is a lead measure, right? The capture rate is a lead measure. It's a process measure. It's not the lag measure, which is the outcome change, which therapists don't have as much control over. There's so much variation with the patients that if they can get this lead measure, if we can say, look, you got control over this, how much of this can you actually collect, then, that makes it easier for them. Secondly, as I mentioned, it's transparent so that they can learn from each other. And fortunately at Intermountain, we're in an environment where this has been going on for 40 years. So for people to say, hey, I got to learn from the guy down the street and see what he's doing or she's doing, that's really common. And so we haven't had problems with therapists having their data accessible to everybody else and learning and sharing from that. This is a huddle board that's on here. So these huddle boards are in every one of our clinics. And this capture rate, along with some of the other outcome changes, are on the huddle board. They're updated every week. And so that therapists see that visually when they're in the break room and that this helps to get some of the engagement. And lastly, as I mentioned, we've integrated this into goals. So the goals of the therapists include, capture rates and also some of the outcomes. Okay. Last couple of slides here. So even though we still got ways to go in Intermountain, I mean, by no means are we reached what we want to be or even close to perfect. There has been some successes that we've had. And why has that been? And what could others learn from that? Well, we have this 40-year history of continuous quality improvement. Fortunate enough to have mentors, a personal mentor of mine, Dr. Brent James, who was in Intermountain and really created this culture of measurement and openness and transparency. We've got really good senior leadership support. All right. And then there's evidence of this. We've got two people sitting here in the audience, Dr. Kate Minnick and Devin Woodfield, and they're full-time rehab specific. Kate's the director of our research. Devin is our data analyst, and they only work in rehab services. And then I've got these other 4 team members that help me. I mean, that's a lot of people not generating revenue that are in a position to help, and that's because of our senior leadership is supportive. And then, as I mentioned, we have these engaged caregivers, and this is part of daily work. All right, so this outcome collection, it wasn't a research project that would start and end at a certain time. It's what we do every day, and we've done this, for 25 years. And fortunately now, because of that, we've got this database of, 4.5 million different visits that we can really use to look at standards and look at benchmarks. So last slide. What are we trying to do here in the future, and where is that taking us? Well, was mentioned, we are also shifting from Cerner, which we've used for many years, to Epic. And so we're wanting to get this outcome collection done within the EHR. Currently it's separate. Devin is the master of just making it look good on the back end by combining it with our EHR data. But we want to actually just collect it all and have it all done through that. So we're working on that. And then lastly, the vision that I have and our team has is to really integrate the outcomes with the best practice evidence with predictive analysis so that we can really get into real-time AI decision assist. I mean, that's the dream that I have before I go off into the sunset, which is that a therapist can come in after one visit, can look at the EHR and it says, look, Stephen, your patient is here. This is what we predict them to get to. This is how complete your eval was based on the evidence by visit 3. That tells me they're on track or they're not. They're not on the trajectory. But oh, by the way, Stephen, you're only kind of 70% adherent with the treatments you're doing that are evidence-based. You might try a couple of these other things to see if that helps the patient get on track. We want that real-time AI feedback and prompting. That's the vision that we have, and to do that within the EHR. So again, some references there and contact information. Again, I'm grateful to be part of this group and mostly learning from all of you. So thank you.